Perfect.
Ladies and gentlemen, thank you very much for the opportunity to talk to you about the use of social media for HPB surgical practice with an academic focus. Unfortunately, I couldn't make it to New York because my university didn't allow me to, but I look forward to a nice discussion for the live Q&A afterwards. Whenever I talk to my parents about social media, it's funny that they still consider it just a waste of time. So I want to start by providing you some numbers to picture the way they are. So social media accounts for 4.6 billion users in the world for an average time of more than 2 hours per day spent on socials. Practically, if you look at these stats, everyone with an internet connection in the world uses social media. In terms of specific socials, Facebook, YouTube, WhatsApp are the most used, but in this presentation we are also going to consider Twitter, which has more than 400 million users in the world. And it's crazy to see how many people can be theoretically reached by a post. For example, on Facebook, it's almost one person out of 4 in the entire world. And Twitter doesn't have the same number, but still is relevant that you can really reach millions of people by tweeting something. So of course, it's not just a matter of HPB surgery, it's something that is related to the entire world. Probably it started from the riots in North Africa in 2011, which have been triggered by social media, as everyone knows. But being in the US, how can we consider how, starting from the former President Trump, Twitter played a major role also for the politics and for the riots that took place in Washington? And I think that coming to the recent days, it's also tragic to see how it's possible to watch actual footage of the war in Ukraine by checking the official account of the Ukrainian government to see the terrible crimes that are related to the invasion of Russia. So going to the HPB topic, I think it's clear that social media have been already incorporated in the clinical practice and in the academic world. The first key message is that socials are made to target their message for specific purpose to specific users. For example, the microblogging social of Twitter is great for journals and researchers to promote their papers, and we're gonna see how. While YouTube, which is the most used platform to share video, is already used, for example, for trainee to share educational video, record lectures or webinars. This is a very famous lecture on how to do the clinic of the abdomen, and the fun fact is that the model used in this video actually had a positive Murphy sign and eventually had a lab coli because of that. Of course, the main issue with the platform like YouTube is that there is no medical curator. So basically the content is not checked for reliability, which is something that exists in other official platforms, like, for example, web search, which is used by residents before scrubbing into a case. But of course, you need to pay for your registration, so the numbers for these platforms are actually way lower than that for Facebook or Twitter. So going to Twitter, this is actually the real deal for scientific papers in HPB. I am sure you know what an hashtag is. The So Made for Surgery hashtag actually built an actual network in the surgical community, since it was created by Professor Julio Mayol from Madrid, and basically because of that, Professor Mayol became a superstar with more than 55K followers all over the world. What an hashtag can do is triggering discussion and building, you see, networks between researchers that eventually can be used to share surgical content. If you are still not convinced about the potential of Twitter, let's do now a little experiment. I am going to post now from my personal Twitter handle this little tweet regarding my presentation in New York. So in a couple of weeks, we are going to see in New York for the Q&A how many people view this post. Waiting for that, I'm going to show you how a scientific paper look like on Twitter. You see how everything is very concise, the language is very plain, some images are chosen, and it's also good to tag the co-authors of a paper or the journal itself to increase the visibility of your post. There are even some professional advice to promote paper on Twitter, and everything is eventually condensated in this visual abstract, which are, let's say, the sexier brother of the traditional scientific abstract, and they are used in social media to increase the visibility of a paper. This is so important that I'm going to show you the email I just received from HPB journal after the acceptance of a paper of mine. You see that now is the journal itself asking to the co-authors with some very nice video to promote their research through social media. And the reason is very simple. In just a couple of years, we saw a shift in the metrics that are used to define how a paper is read and shared. So we now are moving from index like subscribers, citation, downloads, to new metrics that are related to how many times a given paper is read on Twitter or on other social media. This new metric has a name, namely alt metrics, which is basically how many times various social media platform or pickup by media have displayed your research. And why is that so important? Because it is already proven that the higher the alt metric is, the more time your paper will be eventually cited. So for scientific journal, alt metric is becoming really important. Still, a word of caution should be used. Of course, altmetric scores are not surrogate marker for evaluating a research performance nor the impact of a scientific paper. Not just in HPV surgery, but I would say in life, being famous for being famous is not a good thing. And we even have now index to define the discrepancy before and after someone uses social media to promote the research. It's called the Kardashian index, and it's basically the number of Twitter followers versus the number of scientific citation for a scientific researcher. And of course, it was Julio Mayol, the first one to promote such an index with the impressive number of 96 for his case. A resident of mine made fun of me because of this presentation and calculated my K-index. I was very anxious about that. Still, it's very low in my case, probably going a little bit up after this presentation. But anyway, we need now to wrap up what is the role of social media in the HPB community right now. And of course, we need to underline how the reachability of a huge audience can be performed through social media like never before. To share scientific research is now very important, as you saw, and let's say it's also very fun to keep up to date ourselves and to learn through social media, but just by scrolling the video of our smartphone. And particularly in the time of pandemic, is extremely important to maintain virtual connection and even to start scientific discussion thanks to the social media. However, a big word of caution should be used. We know that social media have very serious hacking and security breach issues, and they are run by private companies. Sometimes it's the same company running different socials. So we always have to keep in mind that the big deal here is earning money for the company and definitely not the quality of science. Then we also have some geographical disparities which are very relevant. There are areas in the world without access to social media. And finally, because of the actual lack of a peer review process, there is no scientific control of the content on social media. So I'm going to leave you now with my personal view of the use of social media for the HPB community. And I believe that right now, young trainees who pursue an academic career in HPB surgery need social media. You cannot avoid that, like it or not. Still, of course, you want to personalize your social media according to the specialist you want to become, but be ready to face the consequences of what you do on social media, because it is what it is. What happens on social does not stay on social, it's life themselves. And finally, be able to turn social media off for a while. Maybe I'm saying it to myself. It's great whenever you're able to turn them off, because it's like your brain is expanding and you can get great inspiration by escaping to this social media world sometime. Thank you very much for your attention, and really I hope to see you next time in real life rather than just on social media. Thank you very much.
Thank you, Giovanni. Now we continue with our second speaker, Dr. Ismael Dominguez Rosado from Mexico, the use of social media for HPB surgical practice clinical focus. Ismael, you have 10 minutes.
I think that's a wrong talk, not mine. Good morning. Thanks, Dr. Jimenez, and everybody for the invitation and the opportunity to present these thoughts with you. Fortunately, after watching Dr. Marchigiani talk, it's good that we didn't talk about the same. He probably presented a lot of the data and the academics behind social media. That's a good one. And I'm going to talk a little bit more about the day-by-day use of social media for clinical use. Social media is a great tool. That's something we need to keep up with. Of course, not everybody needs to use it, and we don't need to use all the tools of social media. So probably our generation is more towards using Twitter, not so much to use TikTok. But for sure, we need to use the social media on our benefit. I have nothing to disclose. So this is more or less how I'm gonna go over the talk. And the first topic is that you're able to select your library from social media. As you guys will know, it's very hard to keep up with all the biomedical information nowadays, even if you are just dedicated to 3 organs: liver, biliary duct, and pancreas. And these are some tools that can be useful for us in order to have an organization of our papers. This great application, QXM and Read, it's something that you can use in your phone, in your mobile devices to get journals, the most important journals for you to follow. And if you link it to your subscriptions from your own institutions, you can even download a full text. But even if you are not able to download the text, you can keep up with the abstracts of the most relevant journals for you. And of course, the use of Twitter to follow the tags of the main surgical journals are useful to have an idea of the new papers and the new manuscripts that may be relevant for your practice. This is another use of a good library that's Mendeley. It's for free, and you can build a complete library of papers and organize them in different folders. You can even share these folders with your colleagues, and this is very useful if you want to write a paper or you're working on a presentation. Of course, you know, we struggle with getting information and data, particularly in countries where we don't have good subscriptions to journals. And it's still controversial, the use of Sci-Hub, but it's a reality. Many people in many countries, we use Sci-Hub to get the information we need from our clinical practice. But you also have the opportunity with the use of social media to get in touch directly with the authors and co-authors of manuscripts, and being able to ask them directly to share the preprint or the formal article. So select your tribe. Thanks to Twitter, which is what I'm going to talk more about during this talk, you can actually select the people that you follow and that you're going to see posts all the time on your Twitter history. And these 2 guys, Dr. Ahmad and Dr. Roca, are very active and posting clinical trials and the most relevant papers from HPB published, and they usually start very interesting discussions on these topics, and it's a great learning opportunity for all of us to follow on those threads and discussions to learn about new topics on this area. Dr. Hale and Dr. Catherine Te, they also published many manuscripts regarding neuroendocrine tumors and the use of ICG in liver surgery, and Of course, Dr. Marchegiani, which is an expert of IPMNs, and if you want to know everything new about IPMNs, I recommend you to follow him. And as you can see here, you can actually direct message to him and ask him about his paper and start a discussion. If you post on what he posted of his paper, you can start a discussion about a topic related to a manuscript. This is good, and it's something that probably wasn't that much exploited before these 2 years that we were in our homes during the pandemia. But now, actually, we can get in touch with people through Twitter and start building working relationships. One tool that is very important for Twitter is the save tool, where you can, if you get a good post, something that you want to go further later, to read later, you can actually save this post on Twitter and then go back and download the paper and do some sort of library on Twitter for you so you can use it later. And Twitter also gives the opportunity to listen to other voices. We are probably sometimes very focused on the people that are very high rate publicators on the top tier surgical journals, but from time to time it's useful to listen to other people that work and live in a less favored in countries with a less favored, with a different context of practice, where you can really learn a lot of interesting things. Here I can show you some posts of Dr. Manish Bandare from the group of Dr. Shikrand in the Tata Memorial Hospital in India, and I can tell you he really post very interesting things of surgical practice, and there are some even threads of technical aspects of vein resections, which I strongly recommend that you follow. And this is just a good example of how, besides the opportunity to read the papers for someone who published in HPB or Annals of Surgery, well, actually Twitter can give you the opportunity to learn things from people all around the world. Also, the new HPB podcast, which is an initiative of the Publications Committee of our society. You can listen to this podcast on Spotify for free, and they have interviews of people, not just from the US and Canada and America, from all around the world, where you can learn their experiences and their life practice and the way they become HPB surgeons. And this is particularly good for junior surgeons or people or medical students that are interested to join into surgery and want to know, well, all the steps that these people took before becoming what they actually are. Case discussion groups are also relevant. HPB has not been very active on this, probably because of the privacy liability and problems that they can get into. Here I can show you some examples of the SAGES group and the SSO Virtual Tumor Board, which is a closed group where you can only access if you're a member, and it's all over Zoom. It's also useful to find opportunities of training, like I can show here. You can find even international HPB fellowships on Twitter exposed by, as you can see here, from Dr. Sparolit in Karolinska, or courses for people who already are advanced in their practice, like the one shown here by Dr. Jimenez. And of course, social media has some hazards. You need to be careful. There are sociopaths and trolls all around. Don't get into quarrels. Just use wisely your time when you are over Twitter. Twitter has a problem with immediateness, so you can actually tweet first and regret later if you don't think that what you are tweeting really makes sense. And whenever you get into a discussion, try to be constructive, try to be positive, and use that time to really learn something from another person. Whenever two people disagree about something, that means that one of them knows something that the other doesn't know. So that's why it's very important to be calm and always to be open to listen to the other. And of course, be careful with patient privacy. We should never post things about our patients that we just operated the day before, and never with identifiers, because this can cause us problems, legal problems, because all this is public. In conclusion, social media can help to improve our practice. It can help us to be up to date on the medical novelties and share and disseminate knowledge, network with colleagues, and build relationships with other people all around the world. And of course, we have to be careful with the risk of the immediateness of Twitter about disseminate fake information and to breach patient privacy. Thank you very much.
Please, Ismael. Yeah. Well, thank you for both amazing presentation, and well, time for question, comment. I have one question for both. Is now in the social really two questions. First, is the young people use more Twitter or use more Instagram or another, or in the future our surgical procedures will be in TikTok more than in American Congress? And the second question is, when we read the social media, the artificial intelligence moved the information, and really we read all time the same people and the same ideas. Is the same with when we use in our for the social media for our clinical practice? The artificial intelligence show us all time the same things? Giovanni, do you have? No, it's not connect with Giovanni in Italy? Well, for you, Ismael.
Well, actually, for sure the new generations are using TikTok and much more other different platforms that I don't even know how to use TikTok. Never been on that, but I think we as surgeons and physicians, we just need to use whatever it's helpful for us. We don't need to be in every single different platform. Like, for example, Instagram, it's something that is very useful for plastic surgeons. I mean, that's the way it is. It's useful for them to promote their practice, which I don't think it's probably useful for us because it's completely a different scope of practice. And regarding the other question, for sure there is an algorithm that makes you to see all the time the same people, the people that are related between their comments and their tags. And I think at least from the scientific and the clinical point of view, I mean, that's useful because you're probably, if you use Twitter just to be up to date on your practice, you're probably going to see people tweeting about something that you are interested in, and you will filter other posts of things that are probably not relevant to you.
And the Twitter, for example, is used for the people of 40 or more, but it's really is used for the people with less than 35 years or not?
I think it's useful. I mean, for your clinical practice, it's useful to be, to find your manuscripts and to discuss things with our colleagues. I think it's not dependent on the age of people.
Yes.
Hi, great talk.
It's
Hello.
good.
It's working?
Yeah.
Okay, you can listen. So, how about the Instagram that you say before, and what the limits? Because nowadays we see a lot of people in practice clinic using Instagram to promote the clinic or to promote the surgery or something like this. So, but I think it's maybe too much. But I don't know the limit. How can I use this in a good way and safely and without commit any legal problem with the patient and so on?
Yeah, I think the first limit is to first do no harm. Like never put in risk the privacy of your patients. I think that's number one. And number two, be very mindful on what you post, like to keep it, in a professional way. But as I mentioned before, it depends a lot on your type of practice. Like if you are a cancer surgeon, I don't really see that makes much sense to post, an open whipple on Instagram. Like, what are you trying to get with that, But if you're a plastic surgeon, for sure, you can post all your beautiful reconstructions, and that may be seen by a patient that decides to go to your practice.
Yes, yes. And the end of the day is preserve our patients and the limit of the ethic.
Exactly.
Exactly. Well, another question. I have one more for you, Ismael. Is when we use the social media to say, well, it's the opinion of some paper or show some paper is no problem and it's a good thing. But when it's we resolved to show in Instagram, for example, one short video of our surgery. And with the idea, with the Instagram is possible view for our colleagues, but for all the people.
Well, I think first of all you need to be careful not to post a video or a photo of a surgery that you just did the day before or the same day, because you can actually get in trouble with that. People, I mean, in Instagram and even in Twitter, it's public, so the patient can realize that you are posting something related to him without permission. So I really strongly discourage you guys to do that. I had the impression that on Twitter, it might be useful to post a picture, just like Dr. Bandari does, a picture without identifiers to show the way they did a dissection or the way they do a vascular reconstruction. And I think it's better to do it in Twitter because it's more like a closed a network of more of people from the same area. Like an Instagram, which is completely open, and even someone that is not a doctor or not a surgeon can actually watch that picture and see it. So I think the most important thing is to always keep the privacy of the patient safe, and use your common sense on what are you going to post.
And the last question for me, my part is, Giovanni and you talk about the Instagram, Twitter, etc., but not talk about the Facebook and LinkedIn because it's the past?
Well, I had the impression that it is not being used anymore, like often, and not much for clinical practice. Like Facebook is used most for case discussion groups, but as I mentioned in my talk, people is not very open to that because you can get into privacy problems if you post something or you recommend something in a case discussion group. And LinkedIn, I probably have been there a couple of times, and it's more like a professional, like to find jobs, but it's more like for non-doctors kind of type of job. So I don't think people is very active on that anymore.
Well, thank you very much. Yes, my daughter and son said this Facebook is for the grandparents more than, okay, it's true. Well, thank you very much for the both fantastic presentation. We have on time, and in case it's no more questions, we finish our session. Thank you very much.
Thank you. No se pudo conectar. Sí, yo no lo... Se debe haber perdido la conexión. Muy buena, sí. Dio todo el background académico del social media.
Me encantó. Precisa y concreta, me encantó. Gracias. Es muy fácil hablar y no terminar nunca en esto. Vamos, que tenemos la sesión del otro lado. ¿Ah, ustedes ahora? Ah, pero la pantalla viene después. Acá te voy a la oficina.
Keep session on time. Okay. So I think we are you and me, right? Only. So I have the list here. I was searching for that. So. Yeah, we can do one-on-one. You start. Ladies first. How are you? I'm Eduardo Houghton. Nice to meet you. Good to meet you. I just want to make sure it's the right session. Yeah, it's the right session. You start, right? Yeah. Joshua Davis.
Good. Nice to meet you. I'm here for Indiana. Yeah.
Argentina. Yeah. Okay. We are online. Okay. Yeah. You start.
Okay. All right. Hi, everybody. Welcome. We're going to get started on our session here. The free papers. These are some really excellent abstracts that we're going to have presented to you. Okay, and we'll start with Joshua Davis. He's here from Carolinas Medical Center in Charlotte, North Carolina.
Sorry,
Here.
this mic is out? Yeah.
Okay. Okay. Hi. We're going to present some abstracts here today, and we'll start with Joshua Davis. He's here from Carolinas Medical Center in Charlotte, North Carolina.
Hey everyone, thanks for having me today. I'm Josh Davis. I'm a general surgery resident at Atrium Health, Carolinas Medical Center. Our financial disclosures are listed on this slide. Objectives, first I'm going to go over just kind of the definitions of patient-centered care and patient-reported outcomes. I'll talk about how our institution has utilized mobile health tracking for the recording of patient-reported outcomes, and then go over the data that we've received so far and the steps we're taking with this data. So in 1996, the Institute of Medicine published Primary Care, America's Health in a New Era, and popularized the idea of a patient-centered medical home. This started a wake towards a paradigm shift in American medicine, expanding beyond the primary care clinic and into the wards and specialty offices. There's been a steady shift towards a centralization of the individual healthcare experience. That is around the patient's needs rather than the siloed healthcare system. This shift encompasses an enthusiasm for holistic, coordinated care while holding up the ideals of efficiency, access, and safety. Now, the shift towards patient-centered care has undoubtedly changed the landscape of medicine, but there's still a long ways to go, and healthcare has become increasingly complicated. The National Opinion Research Center was commissioned by the American Board of Internal Medicine to conduct a survey, multiple surveys, evaluating trust in the U.S. healthcare system. As you can see from this distribution chart, reasons for mistrust range widely, but factors that fall within the realm of what's considered patient-reported outcomes account for the majority of reasons for distrust. To quickly define patient-reported outcomes, think about the traditional metrics we follow: morbidity, mortality, length of stay, lab values, and other objective measures related to research and reimbursement models. Patient-reported outcomes, however, focus on what's important to the patient. What do they see, feel, perceive, and are their concerns heard? There are situations where we may be delivering excellent care, but this may go unrecognized and unappreciated by the patient if their concerns fall by the wayside. And I suspect to the majority of physicians and providers in this room, this is all intuitive information, but the question is, again, does the patient recognize our appreciation of this? Mobile health technology is currently revolutionizing medical care, and patient access to communication with the healthcare team is in a place that it's never been before. Our HPB department has utilized this technology for several years for perioperative patient education and monitoring. This technology incorporates into the EMR for notifications and documentation, which are monitored and triaged by our inpatient APP team, the NPs. We send surveys to patients for collection of objective data, such as wound pictures and ambulation status, but we additionally ask questions related to patient-reported outcomes and perception of care. We've previously published on these findings in a pilot study, and the data we're presenting today is our three-year update on this. Sorry, I don't know why I clicked forward. For this analysis, we included adult patients scheduled for elective liver or pancreas surgery enrolled in ERAS preoperatively. These patients would have undergone preoperative screening and pre-surgical classes, which includes enrollment in the Seamless MD application. Patients who enrolled in the application less than 14 days before surgery or 90 days postoperatively were excluded at the time of the data pull for quality of life analysis. We examined application adoption, the survey response rate, and quality of life was assessed through two validated surveys that I'll go over: the Quality of Recovery 15 and the Patient-Reported Outcomes Measurement Information System, or PROMIS. Patients were enrolled between March 2018 and September 2021. There were 462 patients out of 507 who activated their accounts. 303 of these patients were part of the pancreas surgery group, and 159 were part of the liver surgery group. Of those who activated their accounts, 45% completed the preoperative survey, 50% completed the early postoperative survey, and 50% had continued engagement with the application after hospital discharge. Overall, there were 2,130 health checks performed. From those health checks, automatic care recommendations were made using AI logic embedded within the application. 47.8% of patients were offered self-care tips, 20% of patients were instructed to call a nurse, 2.8% of patients were instructed to see their primary care provider, 1.5% of patients were instructed to visit the emergency department, and 28% were given a green light, noted to be on track without further recommendations. Overall engagement in these post-discharge health checks did decline, and it was defined as 1 check per week, and as you can see in the post-operative period, they did start to decline. 51% of patients who completed these health checks said that they prevented at least 1 call to the surgical office, and 11.1% said they prevented at least 1 emergency department visit. Patients were asked in a post-operative completion survey their perception of how the application affected overall confidence and worry related to their surgery. In total, 90% said that the application improved their preoperative confidence, 76% said it improved their preoperative anxiety, 70% said it improved their postoperative confidence, and 64% said it improved their postoperative anxiety. Overall, 90% of people said they would use this application again and recommend it to someone else. Finally, we'll go over the results from the validated quality of life surveys. First, we'll go over the QOR15. This was administered 14 days preoperatively and 3 days postoperatively. In total, 56% of patients took the preoperative survey and 47% took the postoperative survey. The plot on screen left shows results for patients who underwent liver surgery, and the plot on screen right shows results for patients who underwent pancreas surgery. For both groups, analysis demonstrated surgery was associated with a significant decrease in quality of life in the early postoperative period. This slide summarizes results from the PROMISE 10 survey, which was administered 30 and 90 days postoperatively. The plot on screen left shows results for patients who underwent liver surgery, and analysis demonstrated that undergoing liver surgery was associated with an improvement in quality of life between 30 and 90 days. The plot on screen right shows patients who underwent pancreas surgery, and analysis demonstrated a non-statistical difference between groups, indicating that pancreas surgery did not significantly impact quality of life in that time period. So in conclusion, patient-reported outcomes are an important metric to track and analyze. The COVID pandemic has propelled forward the development of a mobile health ecosystem, which is rapidly transforming surgical consultations and postoperative follow-up. Not surprisingly, we found that the use of this technology decreases as patients progress through their postoperative course and kind of resume in normal life. But we feel this is an inevitable outcome as patients recover. However, maintaining use through the 30-day check mark is important for decreasing healthcare utilization and ED visits. Quality of life surveys indicate the initial postoperative period is associated with the highest burden to the patient, and this represents a potential window for holistic care resource utilization. We're currently pursuing integration with wearable health technology, such as kinematic data for mobility tracking, heart rate and oxygen sensors, and sleep cycle information. And it'll be interesting to see how this changes the healthcare, changes our delivery of healthcare in the future. Additional future directions include real-time information availability to patients' primary care providers, especially for assistance with management of minor symptoms and other concerns that may arise, mental health and whatnot. So on behalf of the HPB division at Atrium Health, thank you for the opportunity to present here, and I'll take any questions.
Any comments or questions? No? Okay, let's go to the next one. We're moving for it's Safe Seth from United States, please. Long-term assessment of antibiotic prophylaxis and biliary microbiome in pancreatic duodenectomy.
Thank you for the opportunity to present. We have no financial disclosures. Surgical site infections are a leading complication for pancreatic duodenectomy. Not only they cause severe morbidity, but they also affect survival due to delay in the start of the adjuvant treatment. Despite that, despite the higher SSI rates, the American Society of Health System Pharmacists continue to recommend cefazolin as an antibiotic prophylaxis. Excuse me. In our institution, we conducted a comprehensive review which identified that inadequate antibiotic coverage is one of the reasons for high SSIs. And therefore, in 2015, we decided to switch our antibiotic prophylaxis from cefazolin to ceftriaxone metronidazole. And at the same time, we started to routinely collect intraoperative biliary cultures. This study aimed to summarize the effect of changing the antibiotic prophylaxis on the SSI rates, At the same time, summarize the frequency of intraoperative collected microbiome and how often they cause SSI. This is a single-center retrospective review for pancreatic duodenectomy patients from January 2012 to March 2021. We did a univariate and multivariable analysis to see the effect on changing the antibiotic prophylaxis on SSI, as well as a univariate analysis to see the effect of different antibiotic groups on the microbiome. This is a study diagram. We had a total of 690 patients. 267 were before the change and 423 were after the change. The SSI analysis will be comparing these two groups. Further analysis of the microbiome will be comparing after the antibiotic groups after the change when the intraoperative biliary culture became available. So for the univariate analysis, comparing the two time periods, there was no statistical significant difference in the basic demographics. Preoperative biliary stenting, which is a known risk factor for developing SSI, were actually higher after we started the change. Ceftriaxone, metronidazole by design were used higher after the change, about 75–76% compared to only few cases before the change. And we noticed a decrease in overall SSI rates to about 17% compared to 28% before the change. This decrease in SSI was primarily driven by decrease in incisional SSIs, whether deep or superficial incisional, rather than organ space or abscesses. We also noted a decrease in overall length of stay. To visualize these significant differences, we plotted them against time. On the left side, we can see between 2014 and 2015, with the increased use of SSIs, with the increased use of ceftriaxone metronidazole, which is the green line, there was a sharp decrease in SSIs, which is the blue line, despite a slight increase in the preoperative biliary stenting. On the right side, you can see the association of when the patient developed SSI and the lengthier hospital length of stay. For the multivariable analysis, we sought to determine the relationship between ceftriaxone metronidazole and developing surgical site infection as a dependent variable while adjusting for other covariates. We saw that the use of ceftriaxone metronidazole was associated with 60% decrease of developing SSI, with the odds of developing SSI. At the same time, preoperative biliary stenting was associated with more than 100% increase in the odds of developing SSI, which just highlights the importance of how much of a risk factor it is. Other risk factor was higher BMI was associated with developing SSIs, while other demographic variables were not significantly associated. We also included an operative era variable to account for possible improvement in the surgical technique that might explain why we had lower SSI rates, and here we saw that it was not significantly associated. The second part of the analysis, we looked at the microbiome. We here reported the most commonly isolated microorganism from the surgical site infection and the frequency they appear in the intraoperative cultures. Here we can see when ceftriaxone metronidazole was used, this correlation, there's not really a strong correlation between the two cultures. In comparison, when other antibiotics were used, we can see a strong correlation between intraoperative culture and surgical site infection culture, which indicate poor coverage as those organisms appear in the intraoperative cultures eventually made it to surgical site infection cultures. To quantify this analysis, we here reported the frequency of intraoperative biliary culture eventually caused SSIs. So for gram-positive cocci, about 14% of all gram-positive cocci isolated from the biliary culture eventually caused SSI. This number is significantly higher. About 36% of gram-positive cocci caused SSI when other antibiotics was used, compared to only 7% when ceftriaxone metronidazole was used. Same thing for Streptococcus species, about 44% to 16%, gram-negative and gram-positive bacilli, Klebsiella species, and surprisingly Candida species, which probably attributed to the overall reduction in the bacterial load that improved the coverage against Candida. Finally, we looked at our antibiotic use after we decided to do the change, and we saw that the SSI rates were actually even lower when ceftriaxone metronidazole was used, to about 13%, to when patients have a penicillin allergy and they use other antibiotics, about 27%, which indicate a poor coverage for those patients. In conclusion, broad-spectrum antibiotic prophylaxis provided less surgical site infection in our study, and also provided a shorter length of stay, hospital length of stay. And with that, our internal quality process review provides significant clinical value. Preoperative biliary stenting should be avoided whenever possible, and future efforts should focus on providing better coverage for patients with penicillin allergy. Thank you.
Thank you very much. Any questions or comments? No? I have two for you.
Sure.
Excellent presentation. The biliary stent, it was all by RCP or some of them were percutaneous? And if there was percutaneous, did you find any difference between the percutaneous and the endoscopic stenting?
So the way we looked at in our cohort to define the preoperative biliary stenting is we looked at history of ERCP, and so I don't think in our cohort we had any percutaneous stenting. It's all endoscopically, and that's why the SSI rates are higher, because you're driving gut microbiome into the system, and that's why it was previously reported as a huge risk factor.
Okay. And the second question was regarding the Candida. It is enough data to recommend the prophylaxis for Candida albicans?
So that's an excellent question. Before we looked into this study, we actually were thinking about adding antifungal infection, but then we saw that our Candida infections were actually much lower than it used to be when we used other antibiotic prophylaxis, which now we still don't know. But the data here is showing that it's less likely we have a Candida, even if the Candida was positive in the biliary culture, it's less likely that you develop an SSI with a Candida infection. So the study is not designed to answer this question, but so far it seems to be enough coverage for that.
Okay, thank you very much. Very interesting.
And we have a question from the audience.
Yeah,
yes.
Hey,
Sorry.
Patricio Polanco from Dallas. Excellent work. You presented that data from the cultures of the isolated intraoperatively, right?
Correct.
Were you able to collect samples from the actual infections? Was there a 100% match, or what rate of matching was that? And my second question is, I assume in Cleveland, like many other places, we're doing now more and more minimally invasive approach. Did you assess the impact of the change of antibiotics? Was it equally impactful in both approaches? Because we barely see any infections when we do it minimally invasive in our institution robotically. Thank you.
Thank you. Excellent question. So for the first part, we had about 20 patients total who had intraoperative cultures and also SSI cultures, so like when we can study both of them. We found 80% of those 20 patients have relationship to the intraoperative culture. You know, sometimes it just says gram-positive, but then you grew some gram-positive in the SSI, so you know you can relate it. So that tells us there's strong relationship. However, we're thinking like, how valuable is the intraoperative culture? Should we do it more often? We did not find very good clinical value because most of these intraoperative cultures are multimicrobial. So when the patient actually develops SSI, you don't know which one is developing SSI, so you start anyway with empiric treatment. But you know, to answer your question, yeah, they seems to be related to the intraoperative culture. So that's the first part. The second part, we did not look at it for like open. We did not look at control for open versus MIS approach. But overall, this seems from the previous period to the current period, the surgical technique been stable, been the same. So we don't think that have change, and we controlled for the time variable, so we don't think that have driven by itself, driven the SSI rate low.